This is for everybody who used to check under their bed at night. And so, you double check, you triple check, you just make sure that these things, if they happen, that you're sort of ready and you're sort of prepared to sort of make a good case for it. So is it a tumor? You see these cystic things around the knee. When do you have to worry? Do you ever have to worry? Oh my gosh, where's my wire? I felt something go pop. This personally happened to me at one point. And identify and plan that foreign body removal. It's mostly left leg swelling. Is it May Thurner? Is it worth me treating? Is there something that I could do that might help me understand if it's May Thurner? And is this PAD and arterial claudication? The leg's swollen, I can't feel a pulse. So now what do I do in the clinic? So this is a classic x-ray of a knee with some calcification behind it and a large cystic mass, sonolucent, hypoechoic or anechoic with some internal echoes. This is a Baker cyst. Here we have, I didn't have a picture of my wire that I could easily access, so I just wanted to show you that if you're 90 degrees perpendicular to the plane, we all do this when we're looking for the junctional pictures. We can easily identify that retained foreign body. We see the acoustic shadowing behind it. We can plan a retrieval. Here we have common femoral veins, and we see that on the right side there's absolutely no reflux, and on the left side there's robust reflux. And left leg swollen in isolation, what do you do? What do you want to think about? Of course, here we're going to be able to see that the pinched left iliac vein behind the right iliac artery, markedly thickened echogenic wall with almost no lumen in that area. If you can get up there, here you can see, which you'll see in the iliac vein, as well as you can actually pick it up in the common femoral vein. You're going to see this continuous non-phasic flow. And then last but not least, you put that color box on, posterior tibial artery distally, and there's just nothing in it. And you're at 60 degrees. So remember, you want to be as close to 0 as you can to enhance flow. So we pick 60 because that we can physically do. We can't really get to 0. And 90 when you want to see the echogenicity of something. So it's almost reversed philosophies between the duplex and the Doppler. So a Baker cyst, strictly speaking, is between the gastroc and the semimembranosus. But remember that 40% of all MRIs taken for a patient with knee discomfort have a Baker cyst. So Baker cysts are so common, they can look like masses. They can be complex. If it's around the knee and it's a cyst, it's a Baker cyst. And, it could be a rheumatoid arthritis, hypertrophic synovium. It could be a lot of things, but it's a Baker cyst. You don't really have to worry if it's a cystic lesion. You start worrying when the thing is getting bigger and it's changing, it's mostly soft tissue. Yeah, you can think about it a little bit, but I think for the most part, I don't know if anybody here in this room actually has had a soft tissue mass behind the knee turn out to be a tumor. I mean, I think everybody's seen hundreds of Baker cysts, and it's just so common that it's hard to want to be thinking about the other things. If it ruptures, it'll clinically mimic a DVT, and we've had that a bunch of times come into the clinic. And in that case, it looks very infiltrative, fluid, dissecting along tissue planes. It's not nearly as nicely, sharply demarcated and defined. The broken wire fragment, initially it's that nightmare blood pressure drop. You have to make sure you don't become vagal. And then you get proximal control. So I felt the pop. It was in the calf, in the short staph. And I immediately put pressure at the knee. Control that wire. You do not want that wire flying up to the pulmonary, and it will, unless you're in the tissue. But if a portion of that wire, remember that wire, the flop is not the same as the rest of the wire. The flop is not connected at the same level of resilience. The wire, the flop, if it's not entirely in the vessel and you have stiff wire into the vessel as well. That's just to guide you around those little nooks and crannies that flop, but you need stiff wire in the vessel. If you don't have stiff wire in the vessel, you're going to buckle it, and that's what I did, and then you're going to try to pull or push one way or the other to get the sheath in or whatever, and the next thing you're going to feel is a disconnect. It may uncoil or it may entirely come off. And so proximal control, make sure I see it the entire time. Switch out so someone else is holding proximal control, do a little mini phlebectomy right over the top of that vein and just pull the wire right out. And so it'll be nice and easy. And you can, of course, you have tumescent right there, so you're perfect. Here's the example that, again, I didn't have my own pictures at the time, but again, you're going to see that little mosquito just being able to reach in and grab that foreign body. You're going to watch the whole thing come out, and then you follow it up with an x-ray, and you've had control the whole time, so there's nothing proximal. May Turner, left, 5 times more common in the left leg, but it's not congenital. They autopsied basically babies, kids, for other reasons, obviously. And it's really not present very much at all. It's a few percentage points. But as you grow older and your body changes and there's changes in the pelvis, it becomes much, much more common. 20, 30%, again, MRIs, you can see that compression on the vein. So when does it become symptomatic is when you develop this spur in the vessel, this thickening, that echogenic thick wall that I was talking about before in the external iliac, and you get this continuous non-phasic flow. Now, that's not perfect because, of course, you develop a big collateral. There may be some transmission of pressures, but if you get that, if you're a patient, if a patient presents who's had recurrent DVT in the iliofemoral on the left, that's a trigger for you that you should immediately be thinking that way. If it's a non-DVT patient, then you can do some further evaluation. You can look at the common femoral from one side to the other and see if you have phasic flow. If you have continuous flow on the left, phasic flow on the right, that's a trigger. If you have no response to Valsalva because of the proximal obstruction, that's a trigger. So those things all help guide you to think a little bit more like this isolated left vein disease is worth me treating or not worth it right now. I need more evaluation. And here we go. So this is that same picture from before, and they put the stent in, and the next thing you have is phasic flow and much larger diameter lumen. Want to talk briefly about arterial disease. I got 2 minutes. So we start with a triphasic wave pattern. So we have the brisk upstroke in systole. Diastole, we have an initial dip in diastole reversal of flow, and then some forward flow in later diastole. Remember, this is a high resistance network in the extremities, as opposed to a low resistant like a renal flow, which would have a long diastolic flow. This is unaffected, but very heavily calcified, so it corresponds to an ABI of 1.4. We heard that in Rick's talk. Then we have 0.9 to 1.4, or a TBI. Why do we do TBIs? Because less likely to be calcified in a diabetic, but a non-diabetic, 0.9 to 1.4, a normal triphasic waveform. Then you start losing it between mild and moderate, and this can be difficult to determine exactly how bad the disease is with a biphasic waveform. Is it single level? Is it multi-level? At this point, if the person's symptomology pushes you, this is when you're going to get your evaluation. If they really don't have any arterial symptoms, perhaps you're going to move past this, thinking that it's more mild. But of course, down here, this patient is a severe PAD and rest pain, and a monophasic waveform looks very much like the PVR, this blunted, long slope. Of course, in the PVR, you've lost your dicrotic notch a long time ago. And so we're just going to move on. So here's that occluded vessel. And here, this patient has AFib. So you can see this irregular heart rate, but they do have their brisk upstroke, sharp point, a little bit of reversal, and a small amount of antegrade diastolic flow. So that's a triphasic waveform. And so here's our post-test. And we have this cystic mass behind the knee, but you put Doppler on it, and it's actually a popliteal artery aneurysm. And so just when I said it was safe to go back in the water, wasn't. So popliteal artery aneurysms, again, it's uncommon, but it just makes you think to be thorough, be complete, don't just blow things off entirely. Once you've made the diagnosis of a cystic lesion in the knee, I think you're safe, but you want to make sure that you've really interrogated it properly. And they're very, very often symptomatic. They can have thromboembolic complications. They're almost always treated. One thing I wanted to bring up again, because it was actually in some other talks, but it's also part of ours, or part of what I'm doing, is this popliteal artery entrapment syndrome. That patient is a young person. They come in, they feel great, you feel pulses, but if they hyperextend the knee, if they have passive dorsiflexion, active plantar flexion, and they contract that gastroc, it's abnormal attachment perhaps of that muscle, and over a long period of time it'll cause, even in a short period of time, it'll compress the popliteal artery. Eventually it'll cause synechiae and distortion of the internal architecture of the popliteal artery, and so that person could be either a very muscular athlete or perhaps a truck driver with that constant motion, and end up with a young person, very muscular, showing up in your office with this kind of episodic pain provoked by muscular contraction. And that's it.